Hello, my name is Mark Schroeder. I'm Associate Professor of Medicine at Washington University School of Medicine in St. Louis. I will be talking to you about integrating ruxolitinib for the treatment of acute graft-versus-host disease. It's important to remember that acute graft-versus-host disease is a clinical diagnosis. Typical organs involved include the skin, GI tract, and liver. Skin presenting as a macular-papular rash, GI involvement with nausea or anorexia or diarrhea, and jaundice with liver involvement. The choice of therapy for acute graft-versus-host disease is dependent on appropriate staging of the disease. Recently, a consortium of GVHD centers have developed the MAGIC criteria as published by Harris et al. And shown in this table. This incorporates skin, liver, upper GI, and lower GI staging to develop the overall grade of acute graft-versus-host disease. This allows for appropriate clinical capture and diagnosis of graft-versus-host disease. First, a few notes about graft-versus-host disease grading. Graft-versus-host disease is a clinical diagnosis and is not based on histologic diagnosis. The grade reported by a pathologist is not the grade of GVHD. GVHD is clinically graded. The date of onset of graft-versus-host disease should be considered the date at which a patient starts immunosuppression and is clinically suspected of having graft-versus-host disease. This is essential when determining those who are steroid refractory. Quantification of the severity of GVHD is intended to be standardized by using the MAGIC criteria. GVHD rarely occurs prior to day 14, and alternative causes of graft-versus-host disease should always be considered within the diagnosis. The initial treatment of graft-versus-host disease is often determined by the extent and severity of disease. As reviewed by McDonald et al., patients can be clinically risk stratified to low risk or high risk disease based on clinical symptoms. This allows for reducing the intensity of immunosuppression in those with low risk disease or intensifying treatment for those with high risk graft-versus-host disease. After adequately diagnosing and grading graft-versus-host disease, treatment with steroids should be initiated for those who develop grade 2 to 4 graft-versus-host disease. Steroid-refractory acute graft-versus-host disease is defined as patients who progress on steroids in 3 to 5 days from symptom onset, or if they fail to improve within 5 to 7 days of initiation of steroids, or have an incomplete response after 28 days of immunosuppression. Steroid-refractory graft-versus-host disease has a poor prognosis, with an overall survival of 5 to 30%. There is no standard second-line therapy. Recently, the JAK1/2 inhibitor ruxolitinib was approved for second-line therapy in steroid-refractory acute GVHD based on a phase 3 prospective study. There are only 2 randomized controlled trials evaluating therapies for steroid-refractory acute GVHD. None has shown improvement in overall survival. Ruxolitinib is indicated for the treatment of steroid-refractory acute graft-versus-host disease in adult and pediatric patients. This was based on the REACH1 study that enrolled patients with grade 2 to 4 steroid-refractory acute GVHD. Initial treatment with ruxolitinib was 5 milligrams twice daily, and dose could be increased to 10 milligrams twice daily at day 4. Treatment with ruxolitinib is combined with corticosteroids at a methylprednisolone dose of 2 milligrams per kilogram per day. Ruxolitinib was approved for use based on a day 28 overall response rate in this population of around 55%. The definition of steroid-refractory acute GVHD used in the study of ruxolitinib is shown on this slide. Patients were also considered steroid refractory if they were unable to achieve a 50% taper of their steroid dose without return of their GVHD. The recommended starting dose of ruxolitinib is 5 milligrams twice daily. Patients that tolerate this and have adequate counts can be increased to 10 milligrams twice daily. Ruxolitinib can be tapered starting at 6 months from treatment in patients who are responding and who have been able to be weaned from corticosteroids. Tapering of ruxolitinib was suggested to be performed at every 8-week intervals. In addition, ruxolitinib may be given in the setting of renal and hepatic impairment. Ruxolitinib is metabolized by the CYP3A pathway in the liver, so there are drug interactions to be aware of. It's excreted in urine and feces. In patients with renal impairment, the initial dose should be 5 milligrams daily. Those with stage 3 or 4 liver GVHD or hepatotoxicity should also have dose reductions. It is common practice for patients with steroid-refractory acute graft-versus-host disease to be on mold prophylaxis. And so the co-administration of strong CYP3A4 inhibitors such as voriconazole and posaconazole require empiric dose reductions of ruxolitinib. Ruxolitinib non-hematologic adverse events are summarized in this table. Of interest are increased risk of infections and incidence of hemorrhage. Laboratory abnormalities associated with ruxolitinib are summarized in the table. Cytopenias are commonly observed in patients treated with ruxolitinib for graft-versus-host disease, and this may require dose modifications. Hepatic toxicity can occur, as well as lipid abnormalities. For patients treated with ruxolitinib, monitoring of their blood counts and for cytopenias is essential in the management. Dose reductions or interruptions in therapy for cytopenias should be considered. In addition, monitoring of cholesterol should be evaluated and appropriate therapy administered. Dose modifications for ruxolitinib should occur with the co-administration of strong CYP3A4 inhibitors. In conclusion, the accurate staging and response assessments are key to determine the appropriate therapy for steroid-refractory graft-versus-host disease. Ruxolitinib is the first FDA-approved therapy for steroid-refractory acute GVHD. This concludes the episode. Thank you for your attention.